Hey guys, welcome to the respiratory system. So this is the first recording for the respiratory system. Now, when we look at the anatomy of the respiratory system, this is going to include several organs that are found in the head, neck, and thoracic cavity. This will include all the blood vessels of the pulmonary circuit, which we just got done talking about with the cardiovascular system. We'll also include your rib cage, especially the intercostal muscles, external and internal intercostals. Your respiratory muscle, which is the diaphragm, along with those intercostals, both lungs, and the respiratory tract, which is the network of tubes, conduits, to bring air into the actual lungs. Now, the respiratory tract consists of hollow passages that are collectively going to exchange gases. Each component of the tract has a unique gross and histological structure, and you're going to want to pay a little bit of attention to that. Especially when we get to the alveoli, you're really going to want to understand the actual structure of that. So the nose and the nasal cavity, these are encased within the cranial and facial bones. You then have the pharynx, which is your throat, the larynx or voice box, which is located in the anterior neck, your trachea, or more commonly referred to as the windpipe, is located in the mediastinum, and the bronchial tree, which is a collection of branching tubes which continuously branch within the lungs, all the way down to the bronchioles, and then eventually into the alveoli. So if we look here, you can see the nasal cavity and the nasal passageways. And this is actually a pretty large cavity. I'll put up a cadaver picture as part of the lab for this, where you'll be able to really appreciate that. This is something that, when we are back on campus, that I would encourage you all to at least go and check out in the gross lab. We do have a hemisected head, which is pretty much the view you're seeing here. And it's pretty, it really gives you an appreciation for the space there within the nasal passageways there. The whole function of that area is really to, warm and moisten air, which are two things that have to occur before the air makes its way into the lungs. You then have, and by the way, you should be breathing through your nose, not your mouth, because you get better oxygenation breathing through your nose, because that allows for more efficient warming and moistening of the air versus coming in through the mouth. And you have your pharynx, larynx, here's your trachea, and then we start to get into the bronchial tree there. So the anatomy of the respiratory tract is broken up into upper and lower tracts. The upper tract is passageways from the nasal cavity to the larynx. The lower tract is passageways from the trachea to the respiratory tract's terminal structures, which are referred to as alveoli. Alveoli are tiny air sacs that are arranged in grape-like clusters where the actual process of gas exchange will occur. The lungs, which are a pair of spongy organs located within the thoracic cavity, they are enclosed within the boundaries of the rib cage, as well as with the diaphragm as the floor. Both lungs will actually lay or sit atop the diaphragm. Each lung is a collection of millions of alveoli and their blood vessels. Every single alveolus, as you'll see, is going to be surrounded by a capillary bed. These alveoli are also embedded with elastic connective tissue, which allow them to expand out and then contract back. They sort of act like balloons, with local branches of the respiratory tract. We also break up the respiratory system into two functional zones, the conducting zone and the respiratory zone. The tubes of the conducting zone are just that. They are tubes or conduits through which air travels on its way into, such as inspiration or inhalation, and out of the body with expiration or exhalation. As air is inspired, it is filtered, warmed, and moistened, and this includes the structures from the nose and the nasal cavity all the way up to the bronchioles. The respiratory zone, on the other hand, this is where the actual process of gas exchange occurs. It includes only the structures that contain alveoli. So now let's talk about respiration. Respiration is the primary function of the system. This provides body cells with oxygen, and it also removes waste product carbon dioxide. And this includes 4 separate processes. Pulmonary ventilation. Ventilation is just a term of moving air into and out of the lungs. Then you get pulmonary gas exchange. This is the movement of the gases between the lungs and the blood. This is the whole purpose of the pulmonary circuit, is to move oxygen into the blood, CO2 out of the blood. Then you get gas transport. This is the whole function of the circulatory system, moving blood throughout the body. And then tissue gas exchange. This is actually what happens in the systemic circuit, where now gas exchange occurs between the capillaries and the level of the tissues. So in this case, oxygen would be leaving the blood and CO2 would be entering into the blood, and then you would cycle back up through the whole, back into the whole pulmonary circuit there. As you can see from this, the respiratory system and the cardiovascular system must be intertwined as far as their functions are concerned. They are dependent upon each other. Other functions of the respiratory system are to serve and maintain, mechanisms for speech and sound production. We also have neurons or receptors for the sense of smell. And it is possible to expel contents from the abdominal pelvic cavity, for example, to assist in defecation, urination, and childbirth. This is all by increasing the pressure within the thoracic cavity. Pressure changes in the thoracic cavity will assist with the flow of venous blood. We talked about this yesterday during our outbreak session, where with the venous blood there, you have the problem of trying to get the blood back up from your legs all the way back up. This is the respiratory pump, where we're trying to, with the change in those pressures, draw that blood back up towards the heart. And this does include changing pressure in both the thoracic and abdominal pelvic cavities. It sort of creates a vacuum to draw that blood back up. The respiratory system is also critical in maintaining the acid-base balance of the extracellular fluid, as well as the synthesis of an enzyme involved in the production of angiotensin II. And if you remember from the blood pressure regulation, angiotensin II is critical for the maintenance of blood pressure, and it's tied to that whole renin-angiotensin system with fluid homeostasis. Okay, so now we're going to look at the anatomy of the respiratory system. And we're going to start with the nasal cavity. The nose and nasal cavity are the entryway for the respiratory system, albeit the oral cavity can also serve as an entryway, but you should primarily be breathing through your nose and nasal cavity. And the reason for this is that inhaled air is warm and humidified as it comes in through that nasal cavity. Debris is filtered from the inhaled air. Antibacterial substances are secreted from the mucus into the mucus from the epithelial lining cells. These would also be what we refer to in the immune system as those antimicrobial proteins. The olfactory receptors are housed, and you also enhance resonance of voice through the nasal cavity. Now, looking at the external anatomy of the nose, it is covered with skin that is supported by muscle, bone, and cartilage. Pretty much most of the nose that you see on the surface of your face is cartilage. It is superiorly positioned pair of nasal bones, lateral and lateral cartilages inferiorly will give rise to the external surface features. And you have the root and bridge of the nose are between the eyebrows and the eyes respectively. The dorsum nasi, this is the anterior margin of the nose. The apex is the tip of the nose, and the ala is lateral to the apex, and it surrounds the nostrils, or what we refer to as the anterior nares, paired openings, which are paired openings into the nasal cavity. And here you can see in blue here, this is all an indication of cartilage compared to that. So what you're mostly seeing there is that cartilage, okay, in these various areas we described. Now looking at the internal anatomy of the nasal cavity, inhaled air enters the hollow space referred to as the nasal cavity, framed by bone and hyaline cartilage. It extends anteriorly from the nostrils and the two posterior nares. The nasal septum will divide the nasal cavity into left and right portions, composed of bone and hyaline cartilage. The vestibule, this is the most anterior region of the nasal cavity, just inside the nostril. Bristle-like hairs in this region will prevent large objects from entering into the nasal cavity. The superior, inferior, and middle concha, these are pairs of bony projections or processes of the ethmoid bone. The inferior concha will fill most of the space of the nasal cavity. The nasal concha curl around three narrow passageways, referred to as the superior, middle, and inferior nasal meatuses. These passages will create turbulence that will rid dust from debris of the inspired air. Remember that in the skull, we also have the paranasal sinuses. These are hollow cavities within the frontal, ethmoid, sphenoid, and maxilla bones, and they are connected to the nasal cavity by small passageways. And these paranasal sinuses will also play a very important role in warming and humidifying the air, enhancing voice resonance, and also reducing the weight of the skull. The vestibule, this is lined with stratified squamous epithelium, and it resists mechanical stress. Posterior to the vestibule, the epithelium changes to two types of mucous membrane, an olfactory mucosa and a respiratory mucosa. The olfactory mucosa is located on the roof of the nasal cavity, and it houses receptors for smell. The cribriform plate of the ethmoid bone allows for these bipolar neurons access to the nasal cavity. So posterior to the vestibule, the epithelium changes to two types of mucous membranes. The rest of the nasal cavity is going to be lined with mucosa that is composed of pseudostratified ciliated columnar epithelium. Remember that pseudostratified looks like it has multiple layers, but it's only a single layer. It is going to be ciliated, so it will contain the cilia, and you will also find goblet cells located within this mucosal layer. Goblet cells are unicellular cells that function in the production of mucus. The combination of the ciliated epithelium and the mucus is specialized for air filtration. Foreign particles are trapped in the mucus, and the ciliated cells will actually propel the debris and the mucus towards the posterior nasal cavity and the pharynx. Now looking at the pharynx, which is the next anatomical segment of the respiratory tract, what happens is all inspired air enters, and after exiting the nasal cavity, will pass through the pharynx. It is divided into three anatomical regions. The nasopharynx, which is posterior to the nasal cavity, so just behind the nasal cavity. The nasopharynx is lined with pseudostratified ciliated columnar epithelium, and the main function of the nasopharynx is warming, humidifying, and filtering inspired air. The epithelial lining of the nasal pharynx is not meant for fluids or beverages or food. And you'll see a little bit of a difference in the other two linings of the pharynx, because the other two linings are actually going to be shared with the digestive tract as well. The nasopharynx will extend from the posterior nares all the way to the uvula, which is the part of the soft palate. The uvula and the soft palate will move posteriorly during swallowing, and this will actually prevent food or beverages from entering the nasopharynx and the nasal cavity. Okay. Now, I'm sure that we have all had accidentally had some type of fluid when we're drinking, maybe go up our nose. Okay, and essentially what happens is it did just that. Okay, it went up through that opening that should have been blocked by the uvula and soft palate. So if you don't actively swallow and initiate the process of swallowing, you're not going to close that opening. And again, fluid can go up. Just like if you accidentally inhale something without the act of swallowing, the epiglottis will not actually block the trachea and you can choke. Okay. Now, I will say that if you've ever had fluid go up your nose, you know that it burns significantly. And the reason is that that lining is not meant for that fluid or anything to travel except air. Now, looking at the oral pharynx, this is the next segment. And it's located posterior to the oral cavity. It will extend from the uvula to the tip of the larynx at the level of the epiglottis. And this is now lined with non-keratinized stratified squamous epithelium. So now we're looking at the epithelial lining, and it's much more built up. And the reason for this is that it's more protective against mechanical stresses, as the oral pharynx and the next part, the laryngopharynx, are going to be shared passageways for not only air, but also for anything that you're ingesting orally, such as food and various other substances. The third and final segment of the pharynx is called the laryngopharynx, and this will extend from the hyoid bone to the esophagus. The esophagus is going to be the tube that's going to end up connecting the oral cavity to the stomach. Anteriorly, the laryngopharynx will open into the larynx, which is your voice box, and going to be the conduit into the trachea. Posteriorly, it would open up into the esophagus, which is going to go down the GI tract. Remember that this point is going to be the point of where you're going to diverge between respiratory and digestive tracts. It is also a common passageway for both air and food, and it's also lined with non-keratinized stratified squamous epithelium. So if we look here, we can see we have the nasopharynx in this region here, oropharynx is here, and then the laryngopharynx will be here. Okay, and you can see those different colored zones in this figure here. So now the larynx, this is referred to as your voice box. This is the next anatomical region that inspired air will enter into, and it keeps food and liquids out of the remaining respiratory tract. It's also where you're going to house your vocal cords, which will be very important in speech. It is a relatively short tube that is anterior to the esophagus. The vocal cords create superior and inferior boundary, where two different types of epithelium are found. We have stratified squamous non-keratinized epithelium, which will protect the larynx from mechanical stress, superior to the vocal cords, where both food and air pass through. And then you have pseudostratified ciliated columnar epithelium. This is inferior to the vocal cords. Cilia will serve to propel mucus and debris back up out of the larynx as one clears their throat, quote unquote. There are also, the larynx is going to be made up of 9 separate sections of cartilage, 3 unpaired and 6 paired pieces, which will provide the flexible framework for the larynx. It also is supported by the muscles that connect it to the surrounding neck and by the muscles within the larynx itself. So you have the thyroid, cricoid, and most of retinoid cartilages are made up of hyaline, and the remaining sections are going to be composed of elastic fiber cartilage. Elastic structures found within the cartilage framework are involved in the actual production of sound. So the thyroid cartilage, this is the largest of the three unpaired sections. It forms a shield like the anterior and superior walls of the larynx. It is connected superiorly to the hyoid bone and inferiorly to the cricoid cartilage by the fibrous membrane. And if you've heard the term Adam's apple, this is the anterior protrusion of the thyroid cartilage. The Adam's apple is much more pronounced in males than it is in females. So the epiglottis, this is the next of the three unpaired sections. This is posterior to the thyroid cartilage, and the base is attached to the posterior side of the thyroid cartilage. The superior free edge is not attached to the surroundings. The free superior edge usually stands upright, creating an opening, such as the opening is referred to as the glottis, through which air can just passively pass through on its way into the lungs. The epiglottis will only close in response to triggering the swallowing mechanism. So during swallowing, the larynx is elevated by the surrounding muscles and the glottis is closed by the epiglottis to prevent food and liquids from entering into the larynx. A cough reflex will help to expel food and or liquids that manage to get through the glottis into the pharynx. This also prevents damage to the remaining of the respiratory tract. The cricoid cartilage, this is the third and last unpaired segments. It's inferior to the thyroid cartilage, to which it is connected by a thin membrane called the cricothyroid ligament. Tubes can be inserted through this ligament to provide an emergency airway. So when they do a tracheotomy, they're actually going through the cricoid here, through that ligament, the cricothyroid ligament, in order to place the tube in. The remaining 6 laryngeal cartilages are found in 3 pairs. Together, they will make up part of the posterior and lateral walls of the larynx. You have the arytenoid cartilages. These are triangular. They are involved in sound production, and they attach to the vocal cords and the intrinsic muscles of the larynx. The corniculate cartilages, these are tiny pieces of cartilage capping each arytenoid cartilage. They also function in sound production. And then the cuneiform cartilages, these are located in the lateral walls of the larynx, and they help to overall support the epiglottis. Okay, so next structure is your trachea, or your windpipe. This will be the next structure which air will flow down from the larynx on its way into the lower respiratory tract. It begins with the inferior neck and it will extend into the mediastinum. The trachea is going to be composed of hyaline cartilage rings. And these rings are actually in a C shape, leaving the posterior surface actually uncovered. The rings are supported enough to keep the trachea open, or referred to as patent. As a result, that allows for air to sort of flow through without any resistance. It is flexible enough to allow the trachea to change in diameter during pulmonary ventilation as well. The posterior surface of the trachea is covered with elastic connective tissue and smooth muscle, and this allows the esophagus to expand during swallowing. So when you swallow food, this is going to expand out a little bit, and if you had a cartilage ring right here, that really wouldn't be able to expand out. But because you have smooth muscle here, this guy can actually sort of encroach in here a little bit as he expands out. Looking at the trachea, there's a structure called the carina. This is the last tracheal ring. It forms a hook that curves down and back to back to form partial rings that surround the first branches of the bronchial tree. The carina's mucosa contains sensory receptors that will trigger a violent cough reflex if foreign materials come in contact with them. The mucosa of the trachea, like the inferior larynx that precedes it, is also formed from pseudostratified squamous epithelium as well as goblet cells. The goblet cells, again, will end up producing mucus there. Some people might be familiar with what's referred to as a smoker's cough. This is a deep, rattling cough of smokers that is linked directly to the numerous adverse effects of smoking on the respiratory system. Chemicals in smoke will act as irritants, increasing the overall production of mucus secretions. It will also partially paralyze and eventually destroy the cilia lining the tract. As a result, more mucus is present, but the cilia are less able to sweep out the airways. Cough then develops as only way to prevent mucus buildup. Cilia will then reappear within a few months after smoking stops, and that's why oftentimes you can see a little bit of relief in smoker's cough if you do stop smoking. Now, looking at the bronchial tree, once inhaled air reaches the carina, it then enters either the left or right pulmonary bronchus. This is the first branching from the carina, and each pulmonary bronchus will enter into the left or right lung via a structure called the hilum. Again, this is not the first or last time you're seeing that term, hilum. Hilum is essentially the machine that's responsible for I'm sorry, guys. So once inhaled air reaches the carina, it can enter either the left or right primary bronchus, and it will enter in through the hilum. Again, the hilum is the entry point into the organ. You will see this term used quite frequently with most of the soft tissue organs. Now, in this case, it's the primary bronchi that are entering into the hilum, but you'll also see arteries, veins, nerves, essentially all the essential things that need to enter into an organ to keep that organ functional will enter into these structures referred to as hilums. Once inside the lung, each bronchus will then branch into the bronchial tree, which is a series of progressively smaller tubes that will end in the alveoli. So the primary bronchi, this is the beginning of the bronchial tree, and it's divided into left and right branches at the carina. The right primary bronchus is wider, shorter, and straighter than the left, which is more narrower, longer, and more horizontal. The differences are due to the position of the heart in relationship to the left lung. And you can see right here, the left lung is going to have a little bit of an indentation, and it's going to be a bit smaller. It's only going to have 2 lobes versus 3, first of all. But this is to accommodate this indentation for the heart laying towards the left side of the body. So the right is more likely side for inhaling foreign objects because of these anatomical differences. The primary bronchi will branch into secondary bronchi once inside each lung, and you're going to have 3 secondary bronchi for the right lung, 2 for the left lung. And the reason why you have 2 on the left side and 3 on the right side is because each secondary bronchus will feed into a lobe of the lung. So the secondary bronchi will then branch into about 10 smaller tertiary bronchi per lung and continue to branch into smaller and smaller branches. As the airway divides and gets smaller, the histology changes significantly. The primary bronchi are nearly identical to the trachea, but 3 changes are evident as the bronchi become smaller. The cartilage changes from the C-shaped to complete rings to progressively fewer irregular plates. The epithelium will gradually change from the respiratory epithelium in larger bronchi to columnar cells in smaller bronchi. And the amount of smooth muscle will increase and the hyaline cartilage will decrease as the bronchi will get progressively smaller. Tiny airways must be able to exchange the diameter to control the airflow in the bronchioles of the alveoli. So now let's look at the bronchioles. These are the smallest airways. They features will differ from larger airways. For example, in the epithelial lining, you have simple cuboidal epithelium with very few cilia, if any. They are enclosed within thick ring of smooth muscle, and they are devoid of hyaline cartilage. The conducting zone of the respiratory tract will end at the bronchioles when inspired air reaches the terminal bronchioles. And once you get into the terminal bronchioles, that's going to feed into these alveoli here, which are these little air sacs. And you can see every single alveoli is surrounded by capillary networks. And again, this is going to be the interface for the gas exchange to occur between the air, which is brought in by the atmosphere, as well as the blood, which is being brought by the capillaries. The terminal bronchioles will branch into two or more smaller respiratory bronchioles, and these are surrounded by a thin layer of smooth muscle. The respiratory zone begins with the respiratory bronchioles, with the alveoli budding from the walls. Each respiratory bronchiole branches into two or more alveolar ducts, and they also have alveoli attached to their walls. The alveolar ducts will then end into alveolar sacs, which are grape-like clusters of alveoli. Inspired air has arrived where the gas exchange will now occur. Okay, so if we look at the flow of air through the bronchial tree, what we end up having is the nares will flow into the nasal cavity, the nasopharynx, the oropharynx, laryngopharynx, larynx, trachea, primary bronchi. So now you're into the lungs, right? Once you go past those primary bronchi, that's going to enter in through the hilum, and now you're in the secondary bronchi, which are going into each lobe. Then your tertiary bronchi, then the various branches, the bronchioles, the terminal bronchioles, the respiratory bronchioles, the ducts, and the alveolar sacs, which are going to be your alveoli. So this is the passageway of air through there. Okay. So the alveoli are the final destination for inspired air within the respiratory tract. Each single round of thin-walled alveolus has three cell types. The first is type 1 alveolar cells. These are squamous cells that account for about 90% of cells in the alveolar wall, very thin structural feature, allowing for rapid diffusion of gas or gases across the cell membranes. The type 1 cells are one of three components of respiratory membrane, and this is the barrier through which inspired gases must diffuse. The respiratory membrane, this is formed by the fusion of the simple squamous cells of the alveolus with the endothelial cells of the pulmonary capillary. There is a huge amount of surface area, which increases gas exchange efficiency. Each lung will have approximately about 150 million alveoli for a total of 300 million alveoli, and this just gives you an enormous amount of surface area there. So this is that respiratory membrane there. You can see you have the opening of the alveolus, the lining of the alveolus, lining of the blood vessel, and here you can see blood flow with the red blood cell there. So very, very thin membrane for these gas exchanges to occur. Okay. Each of the alveolus will also have these pores, and this will allow airflow to move from one alveolus to the next. The second type of cell that we find in the alveoli are called type 2 alveolar cells. These are small cuboidal cells that account for about 10% of cells in the alveolar wall and responsible for the synthesis of surfactants. It's a chemical that helps to reduce surface tension on the alveolar walls. The alveolar macrophages, this is mobile phagocytes that are derived from the bone marrow, and their job is really these are resident macrophages, their job is to clean up and digest debris that have made its way into the lungs. A very common disease for the respiratory tract, a very contagious disease for the respiratory tract, is tuberculosis. Tuberculosis is probably one of the most highly contagious diseases, human diseases. This is actually going to be caused by a bacterium referred to as Mycobacterium tuberculosis, which spreads easily via the air, by cough or sneezing. 90% of infections are latent, which means they are asymptomatic, and remaining 10% of cases are active, which means they show symptoms. Symptoms will include persistent cough with blood-tinged sputum, fever, night sweats, and weight loss. It is an alveolar infection that triggers inflammation. Immune cells will attempt to wall off the infected area, resulting in granulomas, which can actually be visible on an X-ray. The diagnosis would be a detection of the granuloma on the X-ray, following usually a positive tuberculin test, which indicates antibodies to the bacterium in the blood, or the presence of the bacterium actually in sputum. Now, just keep in mind that a positive PBD test, which is a tuberculin test, doesn't mean you have an active infection. It just means that there are antibodies present in your blood, which could be because you have an active infection. It could also mean because you had an infection or that you received a vaccine. Treatment is a cocktail of several antibiotics for a period of 6 months, but I've seen as high as 18 months to, in some extent, treat TB. Single antibiotic use to keep latent infections from becoming active. The right and left lungs are separated by the heart and the mediastinum, and the lung's inferior flat base will rest on the diaphragm. The superior apex, which is the pointy part of the lung up top, is going to sit just below the clavicle. The anterior, posterior, and lateral lung surfaces are in contact with the rib cage, called the costal surfaces of the lung. The medial lung surface is in contact with the mediastinum, and that's referred to as the mediastinal surface. And again, I described the hilum earlier. This is a triangular depression on the mediastinal surface, so it's on the midline portion. Located in each lung, where the primary bronchi, blood, lymphatic vessels, and nerves will enter and exit the lung. On the mediastinal surface, you'll also find the cardiac notch on the left lung. This is the point at which it comes in contact with the heart. Each lung is divided into lobes. The right lung has 3 lobes, the left lung only has 2 lobes due to the space required by the heart. The right lung is divided into superior, middle, and inferior lobes, and the horizontal fissure will separate the superior from the middle lobe, and the oblique fissure will separate the middle from the inferior lobe. The left lung is divided into superior and inferior lobe, separated by an oblique fissure. Each secondary bronchus will supply 1 lobe of the lung, and this is commonly called a lobar bronchi. The lobes are further divided by the thin walls of connective tissue into the bronchopulmonary segments. Tertiary bronchi is therefore commonly called segmental bronchi. Each bronchopulmonary segment is further divided into dime-sized hexagonal structures called lobules. And here we can see position of the lungs. This would be the apex up here. Here's the base. And you can see this would be the mediastinal surface here. And you can see on the left lung, we have that little indentation there. So if we're looking at the mediastinal surface, here's that hilum, which is that entry point of, again, the primary bronchi, but also your blood vessels, lymphatic vessels, and nerves. Each lung is going to be found within the pleural cavity. This is a subdivision of the thoracic cavity located between the 2 layers of the serous membrane. The parietal pleura, this is the outer layer of the serous membrane. It's fused to the rib cage, diaphragm, and other local structures. At the hilum, the parietal pleura turns over on itself to create a visceral pleura, which is going to be the inner layer of the membrane, and this is continuous with the surface of the lungs. It dives into the fissures between the lobes. So much like we saw at the heart, the parietal layer is going to be lining the cavity. The visceral layer will actually line the actual organ itself. The pleural membranes will secrete a thin layer of serous fluid, referred to as pleural fluid, that fills the space between the layers and serves to lubricate the delicate surfaces of the lungs as they expand and contract during ventilation. So this is just a table that will summarize all of the various structures from the nasal cavity, which is where we started at, all the way down to the alveoli, which is the end of the structures as far as the end of the line is concerned. It also lists the functions, the type of epithelial. You do want to be familiar with the type of epithelial lining for each of those areas. And then any other histological things, such as are they C-shaped rings, or are they complete rings, or is it smooth muscle? So it just gives you some other features there. Okay, and that is the end for recording number 1.